Anemia is a global health problem affecting 1.62 billion people worldwide and 10 million people in India. WHO statistics say that 1 in every 4 individuals has anemia. Worst affected are preschool age children and women. Every second child and almost every third woman in India is found to be anemic. In today's video, we will be learning about anemia, its classification, pathophysiology, symptoms of anemia especially in women. We will also understand the basic lab tests done to assess a patient of anemia. We will be explaining all of this in a very simple way with the help of flowcharts and animations. So do stick at the end of the video for better understanding of the disease. Welcome to Pathogenesis. This is your first time here. Make sure you press the subscribe button and the bell icon so that you don't miss updates about our next videos. Anemia affects a third of the world's population and contributes to increased morbidity and mortality, decreased work productivity, and impaired neurological development. Understanding anemia's varied and complex etiology is crucial. Let's begin with the RBC. RBCs or mature erythrocytes are unique cells which lack nuclei and cytoplasmic structures. Each hemoglobin molecule is made up of 4 heme groups surrounding a globin group, forming a tetrahedral structure. There are 4 iron atoms in each molecule of hemoglobin, which accordingly can bind 4 atoms of oxygen. Hemoglobin in the red blood cell is responsible for carrying oxygen from the lung and delivering it to the tissues. Many nutrients are essential for RBCs. Iron in hemoglobin normally makes up about 2/3 or more of iron in the body. Copper plays an indirect role by facilitating iron turnover in the body and incorporation of iron into hemoglobin. Vitamin B12 and folic acid play interconnected roles in biosynthesis of nucleotide precursors in nucleic acids, which are required by rapidly developing erythroblast in the bone marrow. Vitamin B6 is a coenzyme in the synthesis of protoporphyrin, which subsequently forms hemoglobin. Anemia is defined as insufficient RBC mass to deliver oxygen to the tissues. This image demonstrates the same. The number of RBCs delivering oxygen have reduced, resulting in less oxygen being delivered to tissues, causing tissue hypoxia. When do we label a patient to be anemic? HB levels of less than 13 in males, less than 12 in non-pregnant women, and less than 11 in pregnant females and children greater than 1 year is classified as anemia. Before moving forward, we will confer a quick framework of erythropoiesis. Human red blood cells are produced through a process named erythropoiesis in the bone marrow. Erythrocytes are continuously produced in the marrow of large bones at a rate of around 2 million cells per second in a healthy adult. RBCs differentiate from myeloid progenitor cells, which are a type of stem cells found in the bone marrow. Erythroid precursors differentiate sequentially from these progenitor cells to erythroblast, normoblast in a process requiring growth factors and cytokines and takes usually 7 days. Normally, erythroid precursors are released into circulation as reticulocytes, which are called so because of the reticular meshwork of rRNA they harbor. They remain in the circulation for approximately 1 day before they mature into erythrocytes after the digestion of RNA by reticuloendothelial cells. The production of RBCs is regulated by a hormone called erythropoietin. EPO is produced in the kidney by peritubular cells that can detect tissue oxygen content. The mature erythrocyte remain in circulation for about 120 days before being engulfed and destroyed by phagocytic cells of the reticuloendothelial system, that is, spleen and liver. Normally, the rate of production of RBCs is equal to the rate of destruction, thus maintaining a balance. Erythropoiesis is stimulated by hypoxia, which can be due to reduced RBC mass, reduced oxygen available, or increased tissue demand of oxygen. These reduced O2 levels in the blood stimulate peritubular cells in the kidney to release EPO. In response to the increased synthesis of EPO, committed stem cells in the bone marrow are increased, thus producing more RBC and thereby increasing oxygen carrying capacity of blood and further normalizing the blood oxygen levels. Symptoms of anemia are due to the decreased oxygen carrying capacity of blood, which causes hypoxia. It is this hypoxia and hypoxia-induced effect on organs causing symptoms of anemia. Many anemias are initially asymptomatic. The diagnosis may be unexpected because the anemia developed over so long a period of time that the patient adjusted to the symptoms without realizing it. Symptoms of anemia include fatigue or decreased energy, dizziness, increased heart rate or palpitations, shortness of breath, and chest pain. Potentially, more serious manifestations include tachycardia, congestive heart failure, and icterus. Clinical manifestations of anemia vary with age, rapidity of onset, and concurrent clinical conditions. Cardiovascular and pulmonary features depend upon the rate of fall in HB, magnitude of fall in, and also the ability of cardiovascular and lungs to compensate. Anemia can be caused due to blood loss, decreased production of RBCs, or increased destruction of the RBCs. Acute blood loss causes a decrease in HB only after 6 hours and causes reticulocyte release after 24 to 48 hours. Gradual prolonged bleeding causes microcytic hypochromic anemia. Blood loss can be due to acute trauma or menstrual or GI bleed. The second cause is decreased production of RBCs, which can be genetic due to bone marrow failure syndromes, Fanconi anemia, Diamond-Blackfan anemia, Shawman-Diamond syndrome, and pure red cell aplasia. The defect can be acquired as in aplastic anemia induced by drugs, toxins, autoimmune disorders, or PNH, parvovirus infection causing PRCA. Functional impairment of erythropoiesis can be due to nutritional deficiency of iron and vitamin B12. Thalassemia or other hemoglobinopathies and marrow infiltration by metastasis, leukemia, or granulomas can also cause myelocytic anemia. Since there is a block in the RBC production, there is a decrease in reticulocyte count of less than 2.5%. Anemia can also be a consequence of increased destruction of RBCs due to genetic causes like hemoglobinopathies, red cell membrane disorders, red cell enzyme defects, and porphyria. Destruction of red cells can be acquired and can be mechanical due to macroangiopathic hemolytic anemia or due to microorganisms and parasites like malaria. It can be antibody-mediated hemolytic anemia or secondary to chemical or heat injury or RBC membrane disorders. Since the destruction of RBCs is increased, there is compensatory increase in erythropoiesis cycle, causing increase in reticulocyte count. Diagnosis of anemia warrants a thorough history and examination, as anemia is not a disease, rather a sign of an underlying disease. Important to ask is the duration and onset of symptoms. A history of cow's milk, which is often responsible for iron deficiency anemia, especially in children taking relevant family histories of bleeding or hemolysis. Menstrual history and history of any underlying chronic diseases is also crucial. Pallor is a common finding in anemic patients. Patients may have bruising or other signs of thrombocytopenia. Thinning of hair, loss of luster, graying can be seen along with the soreness at the angle of mouth. Anemia when severe may produce heart murmurs. Sternal tenderness can be due to underlying acute leukemia. Pica, which is the tendency to eat ice, dirt and chalk, along with spooning of nails, that is koilonychia, are peculiar for iron deficiency anemia. Tingling, numbness and glossitis, along with atrophy of papillae of tongue, are a feature of B12 deficiency. Now let's come to the basic lab tests done for anemia. The red cell population is defined by quantitative parameters, that is volume of packed cell, hematocrit, and red cell concentration per unit volume. Qualitative parameters include mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration. MCV is the average volume of red blood cells. MCH is the average content of hemoglobin per red cell. MCHC is MCH divided by MCV, that is average hemoglobin per volume of red blood cell. On the basis of MCV and on morphology, anemia can be microcytic, normocytic and macrocytic. How do we decide whether a RBC is normo, micro or macrocytic? It is done by comparing the size of RBC to the size of nucleus of a small lymphocyte. RBCs of the same size are normocytic, of size smaller are microcytic and larger are macrocytic. Microcytic anemia can be remembered by the mnemonic CETAL, which stands for sideroblastic anemia, iron deficiency anemia, thalassemia, anemia of chronic disease and lead poisoning. We will be covering details and approach to microcytic anemia in upcoming lectures. Iron studies and thalassemias can be differentiated by iron studies and Menser index. Iron studies are abnormal in iron deficiency anemia. Menser index less than 13 is characteristic of thalassemia and greater than 13 is seen in iron deficiency anemia. Macrocytic anemias may or may not have hypersegmented neutrophils. Neutrophils are said to have hypersegmented nucleus if a single neutrophil has greater than 6 lobes or 5% of the neutrophils have 5 lobes. Macrocytic anemias with hypersegmented neutrophils can be caused due to vitamin B12 or folate deficiency. They can be drug induced also. Hypersegmented neutrophils are absent in alcoholism, liver disease, bone marrow failure syndromes and MDS. Normocytic anemia is generally subclassified on the basis of reticulocyte count. Normocytic with low reticulocyte count of less than 2% can be due to aplastic anemia, PRCA and leukemias. Greater than 2% can be due to hemolytic anemias and hemorrhage. MCH almost always correlates with MCV. MCHC detects severe hypochromia and is the last parameter to fall in iron deficiency anemia. RBC count are reduced in most anemias except thalassemia trait. RDW, which stands for red cell distribution width, detects variation in the size of RBCs, also known as anisocytosis, which is pronounced in nutritional anemia such as iron deficiency and megaloblastic anemia. Peripheral smear examination is very important. It can be critical in picking up small abnormal population which is missed by counters. Important findings such as dimorphic anemia, a leukoerythroblastic blood picture indicating marrow infiltration, rouleau formation pointing towards paraproteinemia, agglutinates in cold agglutinin disease, hemoparasites and signs of hemolysis such as bite cells, schistocytes can be identified only on microscopy. Microscopy can also detect blasts which are seen in leukemia. Should bone marrow be done in anemia? No. Bone marrow is not indicated for anemia. Only in cases of hypoproliferative marrow where greater than one cell line is affected and aspirate might be done. Marrow has to be screened for granulomas, metastatic tumor cells, leukemia, lymphoma, myelofibrosis and pure red cell aplasia. Pearl staining, that is iron staining, is done to assess iron stores in iron deficiency anemia and look for ring sideroblasts in sideroblastic anemia. Bone marrow aspirate also confirms megaloblastic anemia. That's all for today guys. Which type of anemias you encounter most commonly at your center and would like to understand in detail? Do comment in the comment section and let us know. If you liked our video, please press the like button and don't forget to subscribe so that you never miss updates about our next video. You can also follow us on Facebook, Twitter and Instagram. Their links are given right below in the description. So see you soon in our next video.